my disclosures. So what I'd like to do over the next 25 minutes or so is to talk a little bit about PET-MR in the terms of system and workflow considerations, and then talk about its role in metastatic disease, both the current and evolving role as well as challenges that we face in using PET-MRI. So the way we think about PET-MR as a system, you can think of it in three ways. Simplistically, you can think about a PET-CT and MR done separately. And then fuse the data together. That's a PET-MR in some ways. That's technologically easiest to use, but has some issues because you're doing PET-CT and MR on a different time scale, maybe different days, weeks away, and so the information may be temporally different. Other problem is registration. It's different. We do use these kind of things for brain and breast imaging. Registration is a little bit easier. With abdominal organ or looking at abdominal pelvic disease, registration is a big problem. So the improvement on that is so-called sequential system, where you try to overcome some of this limitation. So you have PET and MR done in a sequential fashion, one after another. So a patient is on a gantry and is not moving as much. So you more or less immobilize the patient on a gantry. So registration is easier. And then a PET and MR follow each other, so temporally they are linked. So now that's an improvement in doing a PET-MR. The third system that I have most experience with is an integrated PET-MR system. Here the PET camera is within the MR scanner. Now you're trying to acquire the PET and MR information simultaneously or near simultaneously, and registration is a little bit easier because the information is acquired at the same time. Technologically, it's a little bit more challenging because now you have to make your PET camera to be MR compatible and your MR to be PET compatible. So just want to share some of my experiences. We have had this for about 5 years, and we've done over 2,500 cases with this PET-MR, more or less sequential acquisition. Simultaneous acquisition. The tracer that we've done most or work with is mostly fluorinated compounds, so FDG and sodium fluoride. We have some experience with using 68 gallium dotatate and Axumin for prostate. And we have a cyclotron that just went operational, so we're starting to work with some O15 and carbon compounds, but I won't share some of the data as we don't have enough experience with the system. Just an example here. So this is basically, as the way you look at this is similar to PET-CT, but instead of CT part, you have now MR information. So this is a stitching of the whole body acquisition. You have a T1 contrast, T2 contrast, and this is a sodium fluoride PET-MR in a patient with prostate cancer. So this is sodium fluoride PET. And you basically fuse your PET data with a MR contrast that you would like to see it with. So you can fuse it with T1, you can fuse it with T2. Here we are fusing it with T1 in phase image, and you can see here that you can have a fused PET-MR image. So the question is, why do I care about doing PET-MR in oncology? So this is I don't think it's a published data, but one of my colleagues from MGH, but they showed that PET-CT in their subset of patients over 5 years, about 18% of patients underwent PET-CT and MR within 1 month period of time. And here either MR was used to either troubleshoot, solve something else when the patient started with PET-CT. And the question is, if I'm going to do in 18 to 20% of cases, am I going to do PET-CT and MR as 2 different exams on a 2 different day? Can I not do them together as a one-stop shop? Can I not answer those questions in a single exam? Just take a case that we've had. This was a patient with a large cervical cancer, and you can see parametrial invasion here. And actually on this MR that was done initially, you also see some pelvic sidewall adenopathy. A couple of weeks later, maybe 10 days later, the patient underwent a PET-CT for distant staging. And you can see FDG avid nodes both in the pelvic sidewall and retroperitoneal adenopathy. And the question is, could I have done this all in one-stop shop on the same day and the same exam? So to do that, what is required from the system? What do I need? I need to be able to do a high-quality MR exam of the organ of interest, be it a rectal exam, cervical MR exam. But I also need to do a whole body PET exam and a whole body MR exam. And I need this the quality. I need the PET quality to be same as I would have gotten on a PET-CT, and I need my MR quality to be what I've gotten on an MR system. I can't compromise some of those things with the PET-MR system. And the indications that we can use this as a one-stop shop that we have used in our practice is GYN malignancies, colorectal cancer, neuroendocrine tumors, and we do prostate cancers with, for example, sodium fluoride when they have a high risk for bone metastases. And we do it for recurrent disease using Axumin, which is a fluoclonal that you talked about earlier. And then in our practice, we do And again, it's not be all practices, but we have a lot big lymphoma group and neurofibromatosis group. So again, doing a whole body PET MR as a replacement for PET CT works really well in these cases. So the first question that we need to answer is that is the PET from PET MR same as PET from PET CT? And as I mentioned earlier, that in a PET MR, you need to have an MR compatible PET. The PET camera is different. So instead of photomultiplier tubes, which are not MR compatible, you have a photodiodes, which are MR compatible. So is the PET camera and a PET MR same as a PET on a PET CT? So a number of studies have done this, and they've shown that the PET in a PET MR is highly accurate in detecting activity, and the count of error rates is very, very low. Furthermore, the PET images that you get from PET MR is identical to images you get from PET CT. Here, one of them is a PET image from a PET MR, one is from PET CT, and I actually don't know which one is which, and it doesn't really matter. They give you same morphologic information about the activity and maintain the geometric information as well, which is really important. But the CT that we use for PET CT is not only for anatomic information, but also for attenuation correction. So when you have photons traversing through the body, they're attenuated by the different body organs, bones, soft tissue, and so on. And you need to correct for this attenuation. And CT is great at that because you know your Hounsfield unit is directly proportional to density and it provides you attenuation correction. The problem in MR is that MR signal is not proportional to radio density like Hounsfield unit is. So you need to be able to use some of the MR information to attenuate correct. And so how do we do that? The way most vendors have implemented this right now is so-called Dixon-based MRI method to generate in-phase image, out-of-phase image, water, and fat images. And then each voxel is assigned to 4 tissue classes. Basically, you assign it to either being air, lung, water, or fat. And then once you assign a voxel to one of these 4 tissue classification, you assign each of those tissue classifications some attenuation value. And you basically are saying that in all patients, in all cases, they have the same attenuation value. And I guess I'm thinking now why there are some problems with this, but that's what we do because it's easy to do compared to other techniques. So just showing you here. So you get in-phase image, out-of-phase image, water, and fat image. And then you apply each of these voxels are classified into one of these 4 tissue types, and you get a synthetic CT, a pseudo-CT, or a synthetic CT based on attenuation values of each of these voxels. And then we use this to attenuate correct. So of course the next question is, how good are we? Does this really work? Can we attenuate correct using this technique? And there are a number of papers, and I've just shown you from one of the paper, showing that the mean SUV and the max SUV values between PET CT and PET MR, the difference is quite small for most organs. Again, 0 would mean identical information. And what you see here is that PET MR slightly underestimates SUV mean and SUV max in most tissues except for bone. In bone, you see a significant decrease in underestimation of SUV values with PET MR. And we'll talk about this in a little bit more detail. But what these studies have shown that SUV max is highly correlated, strongly correlated with the SUV max measured on PET MR and PET CT. It's not identical, but strongly correlated. And PET from PET MR can provide information which is similar to PET CT. But some of the issues to think about. One is registration. When you acquire attenuation correction Dixon-based MR images, you're acquiring it as a breath hold. The PET information is acquired in free breathing. So you need to be able to still register the attenuation correction information to the PET information. And if you don't do that well, you get these kind of registration artifact. Another issue to keep in mind, which is purely for PET MR and not on PET CT, is susceptibility artifact on T1-weighted images, because your Dixon images are gradient echo images. Your surgical clips and other metallic artifacts will give you signal loss, and the signal loss would show up on your pseudo CT images and will show up on your PET MR reconstructions. And then talk about the problem with bone. So on Dixon GRE images, we don't really get signal from bone. What we get is from bone marrow, fat, and so on. So what happens is that when you classify those voxels, you're classifying them as soft tissue and not as bone. And if you do that, you basically can understand why now you're basically not attenuate correcting appropriately like a bone, but rather like a soft tissue. And you're going to underestimate SUV max and SUV mean measurements. So the question is, can we use PET MR for then evaluating bone lesions, because you know we're going to underestimate SUV max values. So that was one of our first challenge that we wanted to solve when we got PET MR, was to just ask that question. I know I'm going to underestimate it, but how badly am I going to underestimate it? And is it going to affect in calling a lesion as FDG non-avid while it's FDG avid on a PET CT? And what we found was that actually the underestimation is about 20%, anywhere from 10 to 30% in literature. And we ended up calling all FDG avid lesions appropriately on PET MR as PET CT. So qualitatively, FDG avidity is appropriately seen, but quantitatively, we seem to underestimate FDG avidity. It's about in 20% range in our study. Just look at an example here. This is a fused PET CT where we see a sacral lesion here. On a fused T1 weighted image fused to an MR, T1 weighted MR image fused to a PET, you again see a same lesion here. And on a diffusion weighted image again, you can see a left sacral lesion. In the same patient, there's another lesion there. And on a fused PET MR, you can actually see that lesion in the vertebral body here, again, on a diffusion signal here. In retrospect, it's probably there, but it was difficult to see on a PET CT. Again, this goes to actually thinking about last talk we had, some of the added value that MR provides. There are limitations to detecting FDG less as clearly, but there's some added value that MR provides when looking at bone marrow. So to summarize the osseous lesions, overall, the studies have shown no impact on detectability of FDG avid osseous metastases. SUV max values are underestimated, but MR provides added value. And so what are the added value of MRI when compared to CT? Not just for osseous lesion, but for all lesions. And the reason to think about this in metastatic disease is that we have one PET MR and numerous PET CTs. And most people are not going to replace PET CT with PET MR. That's not really why you would get a machine that's 4 times or 5 times more expensive. The question is, what are the added value where PET MR may able to replace a small portion of patients instead of going to PET CT, you would rather get a PET MR. 20% of the cases as seen in the study before. So you have to think about the advantages of MR compared to CT, like high soft tissue contrast and no radiation, no need for any contrast. Disadvantage is long acquisition time, multiple breath holds. It's expensive. And so try to think about where it adds value. When we think about workflow for PET MR, we think of it in 2 ways. In what situation is my PET MR a replacement for PET CT because I don't want to give IV contrast, I want to avoid radiation, I want to get some more MR and non-contrast MR information that I could not have gotten before. For example, looking at bone marrow. And in those cases, we think of a whole body PET MR exam. This is just like a PET CT where I'm going to do multiple stations, multiple positions, and I'm going to acquire a fast MR in a 5-minute time when I'm acquiring my PET data. And my sequences on MR are going to be the sequences that allow me to do attenuation correction and then give me some additional information. So for us, in our practice, what we do is we acquire coronal Dixon for attenuation correction, and we acquire 3 sequences. We acquire diffusion weighted imaging with 3B values. We acquire axial free breathing T1 GRE sequence because it's the highest resolution, and that's the one we try to fuse with our PET data because it's acquired in free breathing. And we acquire a breath hold single shot FSC, a fast T2 sequence. And many times, depending on the indication, we may add coronal stir to the sequences here. But the idea here is that if I'm taking about 5 minutes per each bed position and I have 4 to 5 bed position, I can do this exam in a table time of 30 minutes or less, room time of 45 minutes. I want to be fast. I want to do it as a survey. And I don't really have a way here to use all MR information that I could have done using this protocol. Again, this is the example I showed you before. This is for sodium fluoride PET MR, where you have a sodium fluoride PET fused to a T1 weighted sequence to look at metastatic disease. Another case here is a lymphoma, where we have a T1 weighted image by stitching all the beds together. This is a T2 weighted image, PET, FDG PET, and a fused PET MR to the T1 weighted image, and you see FDG avid retroperitoneal lymphadenopathy. Here we're trying to take advantage of soft tissue contrast that MR provides over CT. So for example, this is a patient with melanoma where there was an FDG avid lesion. We knew that on PET. On a CT, even in retrospect, it's maybe here, but it was hard to see. And on a fused PET CT, we know what it is. MR, it's much easier to see that lesion on a diffusion weighted image, on a T1 weighted image, and so on. So here we're trying to take advantage of the added value that MR to improve the conspicuity of lesion, improve our confidence, and so on. So another example here is a patient with neuroendocrine tumor where there is a lesion in the pancreaduodenal groove that was difficult to see on a fused PET CT, even in retrospect. But on diffusion imaging, you could actually see this little nodule there that restricted diffusion that actually fused with the PET at the same location, and we're much more confident in making a diagnosis here of a neuroendocrine lesion. But you can also do whole body plus targeted exam. So here you take an advantage of MRI to answer a specific question. For example, to do a loco-distant staging that we talked about earlier. I can use a dedicated exam, for example, for rectal or cervical cancer, or a dedicated exam for liver to look for liver metastases in tumors I know are more likely to go to liver. So I want to be able to do a full liver protocol and do a whole body exam. Again, I don't have to go through this because we learned about the focal liver lesion and advantages of MR, and then able to combine MR and PET for liver lesion can add value. Again, just one of the many papers talked about. This paper talked about the added value of FDG PET MR for detection of liver metastasis. And what's interesting here to notice that PET MRI showed superior accuracy and sensitivity to PET CT, and also improved diagnostic confidence. Interestingly, in this, it's a small study, but what they showed was that PET MR detected additional PET negative metastases in 10 patients for reader 1 and 12 patients for reader 2. Again, here you added value of MRI. PET is the same. If you believe that PET information is exactly the same, this is the added value of MRI over CT in detecting these lesions. Again, we have a big neuroendocrine tumor group. So for us, doing the ability to do, for example, gallium dotatate exam and take advantage of that for looking at neuroendocrine lesions using PET MR has been really valuable. A couple of studies that have shown that using a PET dotatate and using PET MRI compared to PET CT, you get similar information from a PET side, but MRI adds value again compared to CT. We do this quite a bit for rectal cancer protocol, where we do it for local distance staging, but also for neoadjuvant, after neoadjuvant chemotherapy, take advantage of MR and combine with PET to assess for treatment response, to see if it's a complete treatment response or not, and it's been very valuable. As I said, the problem is that you're actually doing a whole body exam plus a dedicated MR exam of a region of interest, and so challenges the time. The acquisition time is now in a range of 45 to 55 minutes because you've added a whole body MR plus dedicated MR. And then the question comes up is how limited are we in detecting lung nodules, right? So the question is, if I'm going to do a PET MR for local distance staging, then I'm going to send this patient to another chest CT. That doesn't really add value. Then now we haven't gone away from one-stop shop to again two shopping sites. So that's really is not very helpful. So the question that we wanted to ask was to see, do we really need additional chest CT? And what we found was that for FDG avid nodules and 5 millimeter larger nodules, PET MR was good. But if you talk about non-FDG avid lung nodules and nodules that are less than 5 millimeter, we miss them all on PET MR. So for small, tiny, non-FDG avid nodules, PET MR is suboptimal. And for ground glass nodules, you're not going to see them on MR. So this is a little ground glass nodule that you're not going to see on a conventional GRE or a single shot FSE kind of sequences, and you're going to miss them. So the question was, what is the outcome of these missed nodules? If I'm going to miss these small nodules, how important are they? And what we found was that in our data that we have with the follow-up, in a so small number of cases, and we have only 3 nodules in one patient with osteosarc, that these nodules progressed to metastatic disease. Almost in every other case, these non-FDG 5 millimeter small nodules were not clinically significant. It depends actually on what tumor you have. So for example, those tumors that give you this tiny little miliary metastasis in the lung, you've got to be careful because you're going to miss them on PET MR. But there's some work being done on lung imaging with MR. The ultra-short echo time sequences are very, very useful because they actually now, they are better than GRE sequences in looking for lung nodules. And there have been multiple papers that talk about the fact that as ultra-short echo time sequences tend to have image quality for accuracy for detecting these small nodules similar to a low-dose CT. We're not there yet, but we're getting there. I'll just show you some example from our practice. So this is, if you do a ultra-short echo time sequence, it takes a long time. And if you do that, you get motion averaged images. If you acquire data over 8 minutes or 5 minutes, you're going to get blurry images. But there are techniques that we use where you can sort that data retrospectively into different motion motion states, and only use the end exploratory data to reconstruct the images, using less data to get better images. Because now instead of average data, you're getting motion sorted data. And this is a 5 millimeter isotropic 1 by 1 by 1 acquired in a 5 minutes, and you get, as you can see here, get an improvement in image quality. And again, this is a data acquired over 5 minutes of free breathing, and this is motion sorted imaging. And this patient had a tiny little nodule here, and you're getting there where you're not CT-like yet because it's 386 by 386 instead of 512 by 512, but you're getting pretty close. And the goal is that if you can get to this kind of quality of MR, then maybe you don't need to do a two-shop examination. So what is PET MR's clinical impact? There have been very few studies actually looking at truly the impact of PET MR and comparing PET MR to PET CT. One of these early papers showed that in this group of patients, where they took all incomers coming in, they got a PET CT and a PET MR, and then they decided to see in how many cases PET MR added value. So what they showed was that in 2 cases, there were findings that were missed on PET MR that were detected on PET CT, so 1.5% of the case. Whereas PET MR added value in 24 cases, which is about 18% of the cases, where something was missed on a PET CT but was detected on PET MR that could be clinically significant and could change management. Again, these are retrospective studies. I think we need to be able to do this more prospectively, which is where the challenge lies. Again, so what I've talked about right now is what we do today, ability to combine PET and MR in a one-stop shop. But that's, to me, it's low-hanging fruits. That's where we want to start because you can do that. The real advantage would be to actually exploit the MR contrast. So PET gives you metabolic information. Conventional MR is good for anatomic information, but you can combine that with diffusion, perfusion, looking at cellularity, stiffness, microstructure, vascularity. Can I combine all this information to get much more information, synergistic information than I get from 2 exams? So the question that comes up is, is diffusion give the same information as PET? And if do so, why would I need to do 2 exams? Why would I do both a PET exam and diffusion if I'm going to get a similar or same information? Again, I'm going to just walk past diffusion images here, but just to show you some data. What this shows you is that if you look at the correlation between the ADC and SUV max, what we find is that there's a correlation, but the correlation is poor. If there's a perfect correlation between ADC and SUV, then the R value should be -1, right? So as ADC goes down, you have hard lesions. And if that was perfectly correlated, your ADC or your R value would be -1. What we find here is R value is in a range of -0.2 to 0.3, which is about a poor correlation. There is some correlation, but it's relatively poor. That applies for different cancers. For example, for cervical cancer or for breast cancer. And what we're seeing here is that MR and PET are providing different information. And then this information may be in some way additive. So it may give you information that's different than you get from a PET exam. So the future potential really is able to combine some of these quantitative MR metrics with SUV to get more information, to do these in to test these hypotheses. So again, this is an animal study and it's really early work, but just going to show you some example of what people are doing. Here they're trying to do a 13-carbon pyruvate MRI to look at the cell cycle information, combine that with FDG information in the same exam, and now you're actually able to try to look at the entire cell cycle of a tumor. And again, so really the goal is this, right? So we've learned so much in the last 20, 30 years about the cell biology, tumor biology. We know all these pathways that interact in some ways for your tumor to go from a single cell to a metastatic disease. And all these therapies are actually designed to block some of these pathways. So you have EGFR inhibitors, telomerase inhibitors, anti-angiogenic agents. They're all designed to block some part of these pathways. And maybe MR can give you information about some of these pathways, and we know we can get that information. For example, doing perfusion imaging and so on, hypoxia imaging. So MR gives you some information. And maybe PET can also give you other information, a synergistic information that may allow you to look at this entire spectrum and look at the different metabolic pathways, and based on the type of therapy, based on type of cancer, maybe we can exploit this information from PET and MR together. So that's kind of where I think the next 5-10 years of using PET MR lies. So in conclusion, using PET MR as a one-stop shop is possible today. Lung imaging is getting better and better, so we can actually do a local and distant staging using PET MR, which we do in our practice all the time. But I think the potential role of combining PET and MR information is where we can better assess tumor aggressiveness or treatment response and provide much more valuable information. So thank you very much for your time.